So students, welcome to this new video in which we are going to complete the hematinics. Now in hematinics, we are going to complete antiplatelets, and then after that we'll take anticoagulants. Then we are going to take thrombolytics, right? And after that, we'll take the drugs which are used in the treatment of iron deficiency anemia, megaloblastic anemia, and growth factors. So I'm taking the more difficult parts earlier because it is better to finish the difficult aspects first and then go on to the easier pathways. So the first part of this video is antiplatelet drugs. Now this is a very important part if you consider it from the competitive exams point of view, because there are many new drugs that have come in this, and then you get many clinical case based scenario questions aate hain aapke isme. To ye wala jo part hai, you please pay attention to that. Now before I start with the actual drugs which are used here, let's first try to understand the pathophysiology of coagulation. So this is the endothelium and this is the damaged endothelium, right? And so this is the endothelial cell. Now, whenever there's a damage in the endothelium, so a damage in the endothelium results in generation of reactive proteins like von Willebrand factor and collagen. And these substances, now here we have our platelets. So these are our platelets, okay? And these substances, then they do what? They activate, they make the platelets active. And platelets के ऊपर receptors होते हैं GP1A and GP1B, इस तरीके के receptors होते हैं. तो ये these receptors they get activated. And activation के कारण क्या होता है? There is this receptor GP2B3A, and then it basically starts aggregating. ठीक है, आपस में they start attaching, they start clumping, and this thing which is there in between them is fibrinogen. ठीक है, so then these platelets they start coming together, and coming together में what happens is further these platelets are activated, and then there is degranulation occurs, and degranulation होके what is released? Thromboxane A2 is released, and ADP. Now thromboxane A2, you all know that this is pro-aggregatory, right? And ADP is vasoconstricting, so they go and attach to the other cells, and then so this like attaches to the thromboxane A2, that is the TP receptor, and this attaches to ADP attaches here, that is P2Y12 receptor. So they go and attach to these receptors, and there is a lot of coagulation, formation of a platelet plug. And this platelet plug matlab basically there is a formation of thrombosis, and there is another agonist, that is thrombin, that is also activated, and that further contributes in the formation of a thrombus. So this is the fundamental of antiplatelets. Now one more thing, that these drugs, this coagulation is more in arteries than in veins, right? So whatever antiplatelets we are giving, antiplatelets as a result will be more effective in arterial thrombus. Okay. Now what are the targets here? Let's see. इस diagram में हमने जो देखे, so what are the targets? So targets यहाँ पे है सबसे पहले thromboxane A2, which is, what is the target for that? We all know aspirin, which is an irreversible inhibitor of COX enzyme, and this aspirin in low doses will selectively inhibit thromboxane A2, right? This we all have studied in last class also of NSAIDs, corticoids, in which I had taken. So the first category, the first target is thromboxanes. Then we have PDE, phosphodiesterase inhibitors, and the drug that we have in phosphodiesterase inhibitor is dipyridamole. Okay, so this is the drug that is a phosphodiesterase inhibitor, and it is acting through this mechanism. There's another drug in this which is known as cilostazol. This is PDE3 inhibitor, and this also has action on the thrombosis. Then the next target is GP2B3A. Okay, so GP2B3A inhibitors, what are they? Because you can see this GP2B3A is playing a major role here. So GP2B3A inhibitors में the drugs that we have is abciximab and tyrofibin and eftifibatide. Okay, then the next target is, we all know that P2Y12 receptor antagonist. They are also ADP antagonist. Okay, so what are the drugs here? Now here we have two type of drugs. One is reversible and other one is non-reversible or irreversible. Now reversible drugs में आते हैं, these are new drugs. They are cangrelor and ticagrelor. And non-reversible में we have ticlopidin and clopidogrel and prasugrel. Okay, so these are the P2Y12 receptor antagonist. There's another, sorry. So this is P2Y12 receptor antagonist, reversible and non-reversible, cangrelor and ticagrelor, and non-reversible, which is ticlopidin, clopidogrel, and prasugrel. Then we have new category, which is PAR antagonist. So this PAR antagonist, in this we have drugs which are known as Vorepaxar and Atopaxar. Okay, so this is the, I'll just give a quick recap. This is the way how which antiplatelet drugs they act. This is the mechanism, like whenever there's a breakdown in the endothelium, there's generation of collagen, von Willebrand factor, which are reactive proteins. They attract the platelets, attach to the receptors, thus the formation of platelet plug starts. There's release of thromboxane A2 and ADP, which go and attach to further platelets and initiate this thrombosis process. Okay, now this is seen more in arteries. So what are the targets that we've identified here? They are thromboxane A2, inhibitor, that is aspirin, low dose PDE inhibitor, that is dipyridamole and silastazole, GP2B3 inhibitor, that is axiximab, pirofidin and actifibetide, P2Y12 receptor antagonist or ADP antagonist, which are reversible and irreversible. Reversible में we have cangrelor and ticagrelor, and non-reversible में we have ticlopidin, clopidogrel and prasugrel, and we have a new category that is PAR antagonist, Warfarin and Atopaxar. Okay, so ये तो था हमारा एक क्लासिफिकेशन. अब इसमें एक एक करके इन दवाइयों को देख लेते हैं. तो एस्पिरिन के बारे में आप सबको पता ही है. अब डाइपिराडिमोल के बारे में अगर मैं बात करूं तो डाइपिराडिमोल बेसिकली इट इनहिबिट्स द फॉस्फोडाइस्ट्रेस एंजाइम एंड thus it increases the cyclic AMP and thus it basically increases the prostacyclin, so it has got an anti-aggregatory effect. There is another drug in the same category, that is silastazole, and this drug is also of the same mechanism, and this drug is used in the treatment of intermittent claudication. Okay, so silastazole is the drug of choice in intermittent claudication. Please don't forget that. Then we come to the category of drugs, that is irreversible inhibitors. So P2Y12, P2Y12 receptor antagonist. So in that we have seen the name of the drugs. What are they? So irreversible जो antagonist थे वो थे ticlopidin, then clopidogrel and prasugrel. Okay, now ticlopidin का एक side effect होता है, it causes severe neutropenia, almost less than 500 per microliter, and thrombocytopenia. ये ticlopidin का side effect होता है. Another important thing, ticlopidin and clopidogrel both are prodrugs, and they are activated by CYP2 C19. And if you remember, omeprazole, which is a PPI, if you have seen my video on GIT, omeprazole inhibits this CYP2 C19 and reduces the action of clopidogrel. This I had explained to you also, that usually when the enzyme is inhibited, then there is usually toxicity, but here the case is opposite. It's a trick that you have to remember, that clopidogrel prodrug में ही convert नहीं होगा if it is not activated. ठीक है, so this you please remember. Then normal side effects, they have more of GIT. Prasugrel is one of the most potent and fastest acting antiplatelet drug, but it has a very high risk of fatal bleeding because it is very fast acting. So fatal bleeding is there in elderly and history of stroke patients. So it has to be used with very मतलब ध्यान से use करने की जरूरत है prasugrel को. Okay, then next category of drugs that we have to see is GP2B3A antagonist. Okay, now these drugs are I'll say they're the strongest antiplatelet drugs. In this, axiximab is a monoclonal antibody. Okay, so apart from axiximab, the other drugs that we have is tirofiban and actifibetide. Now these drugs are good antibiotics, but इनके side effects होते हैं. What are the side effects? Side effect of all the drugs, all the antiplatelet drugs, is bleeding. What are they used mainly in? What are their uses? Used in myocardial infarction, in cerebrovascular diseases, in artificial heart valves. Now there usually a combination of warfarin is given with dipiradimole. So please remember this, don't forget. Then the newer drugs that we are seeing here, newer में एक तो है हमारे reversible CYP2 C19 inhibitors, that is ticagrelor and cangrelor. These drugs are orally effective. Okay, they can be given orally. They have a rapid onset and offset of action. Then they are the first new drug to demonstrate a great reduction in CVD, cerebrovascular accidents, and so they are recently approved by FDA also for the treatment. Right, now another thing, cangrelor is given IV and it is a reversible P2Y12 antagonist, and so it is given as an adjunct to PCI also. Okay, then another new drug is there, that is PAR antagonist, that is Warfarin and Atopaxar. Now these drugs are orally active inhibitors of thrombin receptors on platelets. Okay, which is called as protease activated receptor 1. So that is why they are called as PAR antagonist. So they are basically inhibitors of thrombin receptors on platelet, which is called as protease activated receptor 1. So they are PAR antagonist, Warfarin and Atopaxar. Okay, now after that, let's come to the next part. So this was anticoagulants. Now let's come to coagulants. Coagulants क्या होते हैं? सबसे पहले होता है vitamin K. Vitamin K is the main coagulant. इसमें होता है K1 which is phytonadione, then vitamin K2 which is menaquinone, and vitamin K3 which is menadione. So these are the important coagulants. Now in this, what is the action of vitamin K? Now vitamin K has action. Action of vitamin K is that it basically causes activation of factors 2, 7, 9 and 10. Okay. So vitamin K causes activation of factors 2, 7 and 9 and 10. And how does it do that? I'll write it in red because this is important. It causes gamma carboxylation of glutamate residues. So this is the action of vitamin K, that it causes gamma carboxylation of glutamate residues of factor 2, 7, 9 and 10. ठीक है? So what are the uses? Uses of vitamin K. सबसे पहले it is given when there is a deficiency. Then it is given to the newborns on birth because usually there is a deficiency, they don't have this. Then third, it is given in warfarin overdose. Okay. Then the main vitamin used is K1, which is phytonadione. Then K3 is contraindicated in G6PD deficiency. Then K3 is also contraindicated in newborns. Okay. So this is vitamin K3, which is menadione. So menadione is contraindicated in G6PD and newborns. Remember this. Okay. Now a little bit about warfarin overdose. Warfarin overdose अगर होती है, warfarin overdose में, if it is severe, then give 10 milligram K1 IM followed by 5 milligram 4 hourly. If it is moderate, then give 10 milligram IM followed by 5 milligram once or twice. And if it is mild, then give just omit few doses of warfarin. Okay. So this is a coagulant. Then there are some other agents also about which you should know. They are like fibrinogen, then anti-hemophilic globulin, which is actually factor 8. Then desmopressin. Desmopressin is vasopressin analog, and this is basically because it releases factor 8 and von Willebrand factor. Okay. Then another substance that we have is adrenochrome semicarbazole. Then a substance called as rutin, which is a plant product. Then we have ethamsalate, which is very commonly used in many hemorrhagic conditions like menorrhagia. Then it is used in abortions. Then epistaxis, melena. Then hematuria. After tooth extraction, ethamsalate is used as a coagulant to stop the bleeding. Then we also have some local hemostatics which act locally, and they are also called as styptics. Okay. So इसमें हमारे पास आते हैं fibrin, then gelatin foam, thrombin, then vasoconstrictors like 0.1% adrenaline can also be used, then astringents like tannic acid, right? Then there are some substances which are also called as sclerosing agents. So जैसे piles वगैरह में पहले these substances were used to reduce the bleeding. So there was one substance, polidocanol and sodium tetradecyl sulfate. Right. So these are some substances which are coagulants, starting from vitamin K. Then ये पूरा vitamin K का है, overdose में क्या देना है, and what are the other substances which can be used as coagulants. Right. Now next move to another difficult part of these hematinics, that is anticoagulants. Now anticoagulants थोड़ा सा सबके मतलब because there are a lot of drugs, मतलब ऐसा कमी नहीं है drugs की, lot. So now remember, anticoagulants are divided into oral and parenteral. Okay. Now oral drugs में क्या क्या आते हैं? They are again divided into 3 categories. Okay. सबसे पहले होते हैं vitamin K antagonist. Second category होती है 10A inhibitors. Okay. And third category होती है direct thrombin inhibitors. Okay. Parenteral में हमारे पास क्या क्या categories आती हैं? Parenteral में हमारे पास होती है direct thrombin inhibitors. Okay. Now see, here they are oral, these are parenteral, and then we have indirect thrombin inhibitors. Okay, now let us see their classification one by one. So vitamin K antagonist में the drug that we have is सबसे पहले warfarin, जो हम पढ़ेंगे भी अभी डिटेल में, then dicumarol, then acinocomerin, and then we have phenandione. Okay, then 10A inhibitors में हमारे पास है rivaroxaban, apixaban and edoxaban. Okay, then direct thrombin inhibitors में हमारे पास आता है simelacartan and dabigatran. Okay, you getting it? This is the oral medicines: warfarin, then 10A inhibitors, rivaroxaban, apixaban, edoxaban, and direct thrombin inhibitors are zimelirsen and dabigatran. Then now we come to the parenteral drugs. अब parenteral drugs में direct thrombin inhibitors क्या क्या हैं? तो ये हैं bivalirudin, hirudin, lepirudin, argotraban, and megalatrin. Then indirect thrombin inhibitors में we have three categories. Okay, what are they? The first is unfractionated heparin. Okay, this is in indirect thrombin inhibitors we have three unfractionated heparin. Then we have low molecular weight heparin, जिसमें आती हैं enoxaparin, then dalteparin and tinzaparin. And then we have fondaparinux and iraparinux. Okay, so please see this classification of anticoagulants properly. We have oral and parenteral. इसको याद कर लो, ये याद होना बहुत ज़रूरी है. You need to remember it, मतलब like anything. We have oral, we have parenteral. In oral, we have vitamin K antagonist, 10A inhibitors, and direct thrombin inhibitors. In parenteral, we have direct thrombin inhibitors and indirect thrombin inhibitors. So please remember this. Now let's focus on, let's start the drugs one by one. So the first drug that we take is warfarin. Okay, now warfarin में आप पहले उसको समझो mechanism को. Warfarin actually inhibits the activation of vitamin K dependent clotting factors. Okay, warfarin inhibits the activation of vitamin K dependent clotting factors, which are synthesized in liver, okay, and activated by gamma carboxylation of glutamate residues. What are those factors? 2, 7, 9, 10, along with that protein C and protein S. Okay, now let us see the mechanism. I'll show you the mechanism. Say this is vitamin K, and this vitamin K is in hydroquinone form, and this vitamin K then gets converted into epoxide form. Okay, then this, to convert back vitamin K, to convert back from epoxide form into hydroquinone form, there is this enzyme which is called as vitamin K epoxide reductase. So this enzyme is inhibited by warfarin. Okay, so conversion of vitamin K to hydroquinone form is inhibited by this enzyme, and this hydroquinone form is the one which activates factor 2, 7, 9, 10, protein C, protein S. Okay, so this is the mechanism by which warfarin is actually inhibiting the activation of vitamin K dependent clotting factors. Right, now coming to the warfarin details more. So warfarin is a racemic mixture, and S isomer is more active. Right, warfarin is metabolized by CYP2C9 enzyme. It has got a very short half-life, which is 8 hours. Patients with deficiency of protein C, उनके अंदर warfarin causes dermal vascular necrosis and hypercoagulation. Okay, so patients who are having deficiency of protein C usually present with this problem, with this side effect of warfarin. Then other important things in clotting factors, first to disappear is factor 7, and last to disappear is factor 2. Okay, then oral anticoagulant effect is always delayed. So warfarin usually takes 3 to 5 days to develop the effect, so and are used in maintenance of anticoagulants rather than initiation, okay, of treatment. So remember, initiation of treatment is always done by heparin or heparin products, and maintenance is done by warfarin. This is something that please remember always while treatment also. Then most common side effect of warfarin is bleeding. Whenever there is a bleeding due to warfarin, use fresh frozen plasma or 4-factor concentrate. The most specific antidote is vitamin K. Another important thing about warfarin is that warfarin kinetics change from first order to zero order. So please remember that. Then warfarin crosses placenta and causes fetal Warfarin syndrome. So it is contraindicated in pregnancy. So contraindicated in pregnancy, right? However, it is not secreted in breast milk. So you can give it to lactating mothers, right? To adjust the dose. What are the parameter which is seen for warfarin is prothrombin time and INR. Okay, these are the two parameters. What is INR? INR is PT of patient upon PT of reference. Now INR में आपको देख लेते हैं. If INR is less than 5, then discontinue and restart at low dose. If INR is 5 to 9, then give vitamin K1 1 milligram oral. Okay. If INR is more than 9 but there is no bleeding, then give vitamin K1 2 to 3 milligram oral. If INR is more than 20 and there is bleeding, then give 4 factor concentrate or give fresh frozen plasma. So this is something about the INR. Okay. Now let's see the interactions of warfarin. Warfarin is very, very famous for its interactions. So drug interactions of warfarin. Okay. Now what are the drug interactions of warfarin? Drugs which inhibit the metabolism. That is, which will inhibit the enzyme. So in this we have broad spectrum antibiotics. We have cephalosporins. Then we have aspirin, phenylbutazone, isoniazid, amiodarone, okay, then erythromycin, then cimetidine. So these all drugs will inhibit the metabolism of warfarin, and drugs which will induce the metabolism. So what are they? Drugs which will induce the metabolism: rifampicin, carbamazepine, rhizofulvin, OCPs. So these are the drugs which will which have interactions of warfarin. Now let's move on to the other oral anticoagulants. इसमें हमारे पास था dabigatran, then we have rivaroxaban and apixaban. Okay, these drugs do not require monitoring. Okay, first important thing is that these drugs do not require any monitoring. Then dabigatran is a prodrug, and usually then it gets converted into an active metabolite which then performs its action. So this is these are the, and you know dabigatran is basically a TED-A inhibitor, and rivaroxaban and apixaban are factor 2A direct thrombin inhibitors, right? Then we have indirect thrombin. Let's talk about them inhibitors, because वो भी बहुत बड़ा है उसमें. Indirect thrombin inhibitors में हमारे पास आती हैं unfractionated heparin, then lower molecular weight heparin, and then we have fondaparinux. Okay, now let's discuss about heparin first. What is heparin? Heparin is basically one of the strongest acid present in our body in the mast cells. Now physiologically it is not active. Mechanism क्या है इसका heparin का? It basically activates antithrombin 3 in plasma, and this antithrombin 3 is supposed to do the inactivation of what? Of factor 10A and factor 2A, which is actually thrombin. So ये इसका काम है, mechanism of action है ये. Then ये तो unfractionated heparin हुई. Heparin basically क्या करती है? Heparin accelerates. Normal condition में भी 82 is causing inactivation. Heparin accelerates this reaction, right? So if you see, unfractionated heparin acts on both factor 10A and 2A, right? Lower molecular weight heparin acts mainly on factor 10A, and fondaparinux is seen to inhibit only 83. 83 को, sorry, it attaches, not inhibit, it attaches to 83. So it is again active only on factor 10A. So UFH, that is unfractionated heparin, actually provides a scaffolding on which both the factors are inhibited. I'll show you from the diagram. So this is 83, okay, and this goes and attaches to factor 10A, and there is another factor which is 2A, right? Now unfractionated heparin goes and provides a scaffolding to both, and this is unfractionated heparin, so it provides a scaffolding to both and it inhibits both 10A and 2. Okay, lower molecular weight heparin की अगर मैं बात करूँ, LMWH, lower molecular weight heparin, it goes and attaches only till this. So this is the action of lower molecular weight heparin. Okay, so I'll color this also. And the last one, that is Fonda. This is going and attaching only till this. This is just attaching to this, and so it is causing a conformational change in the 83 antithrombin free in the plasma, and which is ultimately then resulting in a inactivation of these factors. So this is the difference between the action of these three compounds. So please remember them very carefully. Now heparin is monitored. There are simple points which you need to remember here. Heparin monitoring is done by APTT. Then lower molecular weight heparin is given by subcutaneous or IV route, and it does not need any monitoring. Even fondaparinux can be given by subcutaneous route, and it also does not need any monitoring. Fondaparinux is the fastest acting thing. Then antidotes are very important. Heparin का antidote है protamine. Okay, the antidote to heparin is protamine. Then another antidote to dabigatran is idarucizumab. Okay, then antidote to apixaban and rivaroxaban is Andixanet. So antidotes are also very important. Warfarin antidote, we know that it is vitamin K1. So heparin is protamine, then dabigatran is idarucizumab, and apixaban is Andixanet. So these are the antidotes. Now, so uses अगर discuss करें, low molecular weight heparin and fonda, they are used in various जो इनके uses हैं. They are contraindicated in renal failure because they are excreted by the kidney. So this is important. They are contraindicated in IM route because they can cause hematoma. So this is also important. Then they are anticoagulant of choice in pregnancy. Why? Because they do not cross the placenta. So these are important points. Contraindications and choice in pregnancy. Okay. So moving forward, usually LMWH is preferred over unfractionated heparin in wherever there is a requirement, but unfractionated heparin is preferred over LMWH. In which all conditions? Severe CKD. Then if you are giving concurrent thrombolysis, then heparin is not given, right? Then when there is venous thromboembolism, then heparin is not given. And if there is epidural catheter, then also heparin is not given. So this is important. Heparin unfractionated is preferred over lower molecular weight heparin when if there is severe CKD or if there is concomitant thrombolysis or venous thromboembolism or epidural catheter is there. The side effect is bleeding, and so you have to use FFP whenever there is a bleeding. Then a major side effect is heparin induced thrombocytopenia. So this is a side effect which is seen with heparin. So this is also called as HIT. So in this there is basically paradoxical thrombosis. Okay, and so there is paradoxical thrombosis, and test is serotonin release assay. In this contraindicated होते हैं heparin, warfarin, right? LMWH, सब कुछ. Nothing is given. Then what is given? Anticoagulant of choice. The drug that is given is direct thrombin inhibitors. Okay, that is lepidolin and bivalirudin. Fondaparinux can be used. Okay, so this is something which is there. Another important thing I wanted to tell is that heparin is drug of choice in DIC. That is, it is used in the disseminated intravascular coagulation. This you must have heard also. So this is the part there. Now let's just compare heparin and warfarin. If we just compare them, heparin can be given IV or subcutaneous. Warfarin is always given oral. Heparin is rapid acting, so it is used to initiate the therapy, and this is slow acting, so this is used for the maintenance. Then it can be active in vitro and in vivo both. That is heparin, it is active only in vivo. Then it acts on factor 10A and 2. This acts on factor 2, 7, 9 and 10. Monitoring is done by APTT, monitoring done by PT. Antidote is protamine, antidote is vitamin K1. Then it can be given in pregnancy, does not cross the placenta, it crosses. Okay, so these are the important points related to heparin. Now let's come to the next category, that is direct thrombin inhibitors. So इसमें direct thrombin inhibitors में the drugs which we had are hirudin, lepidolin, bivalirudin, ergotroben, then dabigatran and melagatran and zimelagatran. Now we know dabigatran and zimelagatran, I have told you earlier also, these are prodrugs and they are activated to their active metabolites. Then these are given orally, right? And rest all are given parenterally. Okay. Then these drugs, they directly inactivate factor 2A, that is also called as thrombin. This is the anticoagulant of choice in heparin induced thrombocytopenia, right? साइड इफेक्ट इनका होता है ब्लीडिंग, जिसके लिए यू हैव टू गिव देम FFP and monitor by APTT. Then all are excreted by kidney except ergotrobin. Okay, ergotrobin is secreted by bile. This is something important about ergotrobin, and it also, what does it do? It increases the INR also. ठीक है, then आगे बढ़ते हैं. Lepidolin is used in liver diseases. Then bivalirudin has shortest half-life, right? So these were the important things related to the direct thrombin inhibitors. Okay, now a few important points in this. Warfarin preferred, ये इसके ऊपर lot of questions they are asked, so you should know. First, warfarin is preferred in patients with mechanical prosthetic walls. Second, warfarin is preferred. You will get many clinical case scenarios where they will give you a case scenario and then you have to identify which anticoagulant to give. So please remember this. It is given in prosthetic walls, it is given in advanced kidney disease, it is given in moderate to severe mitral stenosis, and when a patient cannot afford. Okay, it is also given in patients with chronic atrial fibrillation. Okay, so this you have to remember. I have told you about the antidotes. Antidotes I have told you that rivaroxaban, apixaban antidote is Andixanet and dabigatran ka edarizumab. Then let us see some other anticoagulants are there. One is danaperoid. Now danaperoid is a mixture of 84% heparin sulfate plus 12% dermatan sulfate plus 4% chondroitin sulfate. Danaperoid is used in prophylaxis of DVT. Okay, so remember this. Danaperoid can also be used in HIT. Then if rodenticide poisoning is there, rodenticides, they have these hemolytic agents, these anticoagulants. So then the antidote is vitamin K1. Then there is another drug which is Tranexamic alpha. This is recombinant human activated protein C. So these are some few more drugs in anticoagulants: danaperoid and rodenticide poisoning and Tranexamic alpha. Then next thing that we have to take up in this is thrombolytics, right? तो thrombolytics का mechanism of action क्या होता है? तो thrombolytics बोलते हैं या इसको बोलते हैं fibrinolytics. As the name itself suggests that they basically lyse the fibrin. So suppose there is fibrin and this fibrin is broken down into fibrin degradation products. Okay, how is it broken down? It is broken down by a substance which is called as plasmin. And ये plasmin कहाँ से आया? ये plasmin आया plasminogen से. This is the plasminogen. It gets activated to plasmin and then this plasmin breaks fibrin into fibrin degradation. Now this plasmin is activated by tissue plasminogen activator. Okay, so this tissue plasminogen activator is the thrombolytic that we have. So the various drugs that we have is streptokinase, urokinase, altiplase, tenecteplase, retiplase. Okay, streptokinase is obtained from beta hemolytic streptococci. Urokinase obtained from urine, and all these three products are recombinant products. Okay, so this is the mechanism of action by which we have this. Now remember that streptokinase, then there is another substance, Anistreptase. Now what is this Anistreptase? This is a combination of streptokinase plus lysoplasminogen. Now streptokinase, remember, it is antigenic, right? Antigenic hota hai, and that is why it is not preferred nowadays, but it is cheap, so people normally go for it. Antistreptase is also antigenic, so that is one side effect with this. But antigenic ke saath benefit hai, you can give it as a single IV bolus. Okay, then next thing about fibrinolytics, that streptokinase and anistreptase and urokinase, they can activate circulating as well as fibrin bound plasminogen. Okay, so this is streptokinase, anistriclase and urokinase can activate the circulating as well as fibrin bound plasminogen, while retiplase, tenecteplase can activate only fibrin bound plasminogen. Okay, now these drugs are used in acute MI, acute stroke and also DVT. Overdose होने पर what do they cause? They cause bleeding, right? Retiplase and tenecteplase, they are longest acting, and so they are also called as bolus fibrinolytics. Now अगर इनकी dose ज़्यादा होगी and there is bleeding, so what is the antidote? Antidote to these substances is EACA, epsilon aminocaproic acid and tranexamic acid. Okay, and what is the mechanism? Now what are these substances called as? These substances are called as antifibrinolytics. Okay, epsilon aminocaproic acid, it inhibits plasminogen activation and inhibits the dissolution of clots, right? This is a specific antidote for the thrombolytics. Now what is the adverse effect? There is a risk of thrombosis. They can result in thrombosis, they can result in ureteric obstruction. Then tranexamic acid. Tranexamic acid is 7 times more potent than EACA. It is preferred for control of bleeding. In which conditions? It is preferred for control of bleeding during bypass surgery, during surgery in hemophilic patients. So it is used in menorrhagia, thrombolytics. It is also used in epistaxis. Then also used in post-radiation bladder bleeding. So these are various uses of these antifibrinolytics. Now coming to the growth factors. Okay, now what are the growth factors which play a very important role? Now growth factors, let us make a classification first and then we'll take the growth factors one by one. So RBCs का जो growth factor होता है उसका नाम है Erythropoietin, and the drugs which we have are called as Epoietin, Darbepoetin and Peginacetide. Okay, so these are the drugs and the indications are that they are used in anemia in chronic renal failure, myelosuppression and also in cancer chemotherapy. Okay, so these are the growth factors of RBCs. Then WBCs, the growth factors are called as G-CSF and GM-CSF. Okay, now G-CSF the जो drug है that is filgrastim, and we also have a pegylated version pegfilgrastim. Okay, and GM-CSF का we have sargramostim, and another drug is there that is volgramostim. Okay, and these drugs they are mainly used in neutropenia and cancer chemotherapy, myelosuppression. Okay, so these are the RBCs, these are the WBCs. Next we have platelets. Okay, now platelets में what are the growth factors? One is interleukin 11 and thrombopoietin. Okay, so what are the growth factors for interleukin 1? We have oprelvecin, and thrombopoietin के लिए we have romiplostim, then we have eltrombopag, then we have avatrombopag andlustrombopag. Okay, and they are used, this is used in thrombocytopenia, and romiplostim used in idiopathic thrombocytopenic purpura, thrombocytopenia due to liver diseases. Okay, so this is the summary of the growth factors that we have to remember: RBCs, WBCs and platelets. RBCs में it is darbepoetin, peginacetide, WBCs filgrastim and sargramostim, and platelets it is oprelvecin and romiplostim. Mainly तो ये आपको याद रखने. Okay. Now there is anemia due to CKD. Okay, so here what happens is actually hypoxia causes production of HIF, that is hypoxia inducible factor, and this HIF, it is responsible to increase erythropoietin production. Okay, now there's an enzyme. This HIF is degraded by enzyme prolyl hydroxylase. So we have made a drug which inhibits this enzyme, that is daprodustat. This inhibits prolyl hydroxylase. Okay, and there's another drug, that is vadadustat. So these two drugs, anemia due to CKD, we use these two drugs, that is daprodustat and vadadustat, which inhibit the prolyl hydroxylase, which metabolizes or degrades the HIF. Okay, remember this. The other drug that we have seen in the classification, peg-inositide. Now this peg-inositide is a new drug which is called as erythro-stimulating agent, ESA, right? It is also used in anemia, in CRF, in patients on dialysis. If the patient is on dialysis, then we can use this peg-inositide. Okay, then G-CSF drugs, they cause capillary leak syndrome. Okay, then I have also told it there also, oprelvecin is interleukin 11 analog, and it is used in thrombocytopenia due to cancer chemotherapy, right? Then we have romiplastin, which is a new drug again. Okay, and it is basically peptide bodies. Peptide bodies का क्या मतलब होता है? They are peptides plus antibody fragments. It is used in ITP. Okay, romiplastin. A very important factor, all are given by subcutaneous route. Remember this. All these drugs that we are discussing are given by subcutaneous route. Then another new agent I would like to tell you, which is spleen tyrosine kinase inhibitor. Right? What is the name of that? That is fostamatinib. Now spleen tyrosine kinase inhibitor. इसको कैसे याद रख सकते हो? यहाँ पे fostamatinib, spleen tyrosine, right? So spleen tyrosine kinase, actually it is required for cytoskeletal rearrangement in macrophages for phagocytosis of platelets. So by this drug will inhibit the spleen tyrosine kinase, and so that cytoskeletal arrangement will not be done, and the macrophages will not be able to phagocytose the platelets. So it is also used in the treatment of ITP. Okay, then eltrombopag is a new drug which is approved for ITP. It is a thrombopoietin agonist. Then there's another drug, evotrombopag and lucitrombopag. These are new oral drugs, again used for ITP, thrombocytopenia in adults with chronic liver disease, scheduled for surgery. Okay, evotrombopag and lucitrombopag are new oral drugs which are used in ITP, thrombocytopenia in adults with chronic liver disease who are scheduled for surgery. Okay, then there is a drug which is called as luspatercept. This is a new drug approved for treatment of anemia in patients with beta thalassemia and myelodysplastic syndrome. Okay, this is basically active against TGF beta, transforming growth factor beta. This is basically a fusion protein against TGF-beta. So luspatercept is used for anemia in patients with beta thalassemia and myelodysplastic syndrome. So this was about the growth factors. Now the last part of this whole video, that is iron, folic acid and vitamin B12. इसके ऊपर आते हैं. So iron, daily requirement of iron in adults it is 1 milligram. In menstruating females it is 2 milligrams, and in pregnancy it is 3 to 5 milligrams. So in this, the daily requirement is this. Then sources, you can get it from dietary liver, then egg yolk and beans and dry fruits, right? Now an important thing about iron, that it is absorbed in ferrous form. Okay, so ascorbic acid and HCl, they increase the absorption, and alkalis, phosphates, phytates, tannins and tetracyclines, they reduce the absorption. Okay, storage of iron in our body is done as ferritin, or it is transported in the blood as transferrin. Okay, as ferritin it is stored in the mucosal cells. Now in iron deficiency anemia, there's an increase in the transferrin receptors on RBCs for erythropoiesis. Prophylactically we give iron IV, IM when oral is not absorbed, not tolerated, or along with erythropoietin. Why with erythropoietin? Because when there is rapid erythropoiesis, then iron चाहिए ना body में बनाने के लिए hemoglobin. What are the oral salts that we have? We have ferrous sulfate, ferrous gluconate, ferrous succinate, and these drugs, they give 20% elemental iron in 1,000 milligram in 3 divided doses in a day, in 1 day. How do you measure the response to iron? There's an increase in the reticulocyte count in 2 weeks, and it peaks in 4 weeks. Okay, oral iron needs to be given for at least 3 to 6 months to bring the hemoglobin to normal. What is considered as adequate response to iron therapy? If the increase in hemoglobin is 0.5 to 1 gram per deciliter per week, then it is said that yes, the iron is growing up or increasing properly. In pregnancy, start iron in 2nd trimester. Why? Because it causes nausea and all, and it will increase the morning sickness of the 1st trimester. What are the adverse effects? It causes epigastric pain, nausea, vomiting, metallic taste in the mouth, right? Now there is another salt, ferric citrate. It binds to phosphates and forms non-absorbable complexes. Ferric citrate binds to phosphates and forms non-absorbable complexes. So it is indicated to control hyperphosphatemia in patients with CKD on dialysis. Okay, remember this ferric citrate, and it is given orally. It is given because it binds to phosphate, and so it is used to control hyperphosphatemia in CKD on dialysis. Okay, आगे बढ़ते हैं. Parenteral iron preparations. Now parenteral iron preparations में we have iron dextrin, iron sorbitol citrate, ferrous sucrose, ferric carboxy maltose, and iron isomaltoside 1000. Right, now this drug is given by IV or IM route, but these drugs are given by IM route. Ferrous sucrose is given by IV route, carboxymaltose by IV, and this is given by a single bolus IV, and they are found to be effective. So these are the parenteral iron preparations. How to calculate iron requirement? The formula is 4.3 into body weight into hemoglobin deficit. It is a very simple formula, and it is also asked in the MCQ, so please remember this formula. Then injections given by intramuscular. Z-track technique to avoid pigmentation, right? To avoid pigmentation. Now there is iron poisoning. Iron poisoning में हम acute में क्या देते हैं, chronic में क्या देते हैं? So acute poisoning में we give desferrioxamine, it is given by intramuscular route. We can also give DTPA or EDTA. In chronic we give deferriprone, and contraindicated is BAL because it unnecessarily causes more toxicity, it is contraindicated in iron poisoning. So this is about the iron poisoning treatment. Then next we take folic acid. Now folic acid is basically in the body, it is reduced to dihydrofolate, then it is reduced to tetrahydrofolate, and this is then methylated tetrahydrofolate, which is then used in many 1-carbon transfer reactions. Okay, and in that one very important is conversion of homocysteine to methionine. Right, this is conversion of homocysteine to methionine is something very important, and for generation of thiamidylate, which basically requires vitamin B12 as well as folic acid. So this reaction, if there's a deficiency of folic acid, will result in megaloblastic anemia. Okay. Now folic acid is useful in pregnancy to prevent neural tube defects. Then in methotrexate toxicity, we use leucovorin, which is actually reduced folic acid, THFA or folinic acid. So we are giving it directly by bypassing that reaction, and it is also called as erythropoietin factor, and it is called as rescue. Then it is also given to enhance the anti-cancer efficacy of 5-fluorouracil, whatever, 5-fluorouracil. Okay, so these are important points related to folic acid. Coming to vitamin B12. Vitamin B12 is cobalt, cyanocobalamin, and hydroxocobalamin. It is mainly obtained from animal foods. In vegetable source is only legumes. Now what happens is this vitamin B12 combines with intrinsic factor and is absorbed in terminal ileum. Okay, then from there it is blood में जाता है in combination with transcobalamin 2, right, and it is then converted into active, which is methyl cobalamin and deoxyadenosylcobalamin, and from here it again used in many important reactions like conversion of methyl malonyl coenzyme A to succinyl coenzyme A. One is this reaction, the another is conversion of methionine to S-adenosyl methionine. Okay, so this is the importance of vitamin B12. Now you will say, ma'am, ये क्यों बता रहे हो आप? Why are you telling us these reactions? These are important because you need to understand the basics, why they are important. Now deficiency of vitamin B12 causes megaloblastic anemia, right? And loss of myelin happens when there's a deficiency of vitamin B12, and it results in subacute combined degeneration of spinal cord. Okay, so this is a very important side effect. You should remember subacute combined degeneration of spinal cord caused by deficiency, and what it causes is loss of vibration and proprioception. There is paresthesia, depressed stretch reflexes, mental changes, and poor memory and hallucinations. Why? Because it causes, the symptoms are related to lesions of posterior column of spinal cord. Okay, ठीक है? So vitamin B12 is used in treatment of megaloblastic anemia. It is given intramuscular or subcutaneous for pernicious anemia. It is also given for neurological abnormalities in diabetes mellitus patients, and it is also given in tobacco amblyopia. There hydroxycobalamin is used. It combines with cyanide and it forms cyanocobalamin. Okay, so with this we complete the chapter of hematinics. Now tomorrow I think I'll be taking a combination of PNS and kidney, small topics. We'll complete that.